Good morning again. Another slideshow. This one's just to show how do we set up a 12 lead. This is something that we're going to be using as we transmit our information over to the hospital, especially if we find somebody that is having an active STEMI or ST elevation MI. This is a great tool for notification and identification of an active MI that will dramatically increases the patient's chance of survival, because the time from our assessment to the time they get to the cath lab where they need this life-saving treatment for catheterization can be shortened dramatically by doing this. So real quick, we're going to go over to the 12 lead and move forward with that. Keep in mind, as we move forward, when you move forward, you have your EMT certifications and you're off to your agencies. If you're working on a BLS level, you may know how to do this due to the curriculum we're teaching you. However, this is going to be a specific skill that is approved per agency, as approved by the medical director of that agency. So this is one of the reasons for is because of the agency specific equipment that goes with that, and also the utilization of BLS providers at those agencies. So there's my disclaimer. Let's get on with it. So let's talk about a pre-hospital 12 lead. So we talk about the acute coronary syndrome. So there is an actual whole protocol that falls under this. And if you haven't done so yet, and you may have heard me say this in another presentation, if you haven't looked at the New York State BLS protocols, please do so. They're not hidden, they're not secret, they're on all over the web. All you got to do is New York State BLS protocols, and it'll bring you to the New York State DOH website that has all of those. There's also apps for that. We follow the Muru app in New York State, which our region falls underneath. Under that Muru app, especially after you get once you have your credentials entered, you will be able to have access to anything. All you have to do is put what the patient's problem is, acute coronary syndrome problem. It'll bring you up the protocol and everything you can do on that level up to a certain point. There's also the New York State collaborative protocols. There is an app for that. Problem with that app is it's not updated constantly like the Muru app is. So keep that in mind moving forward, but let's talk 12 lead. So acute coronary syndrome, we're going to follow the New York State BLS protocol for adult-related cardiac problems. So we're going to attach a cardiac monitor. We're going to obtain a 12-lead EKG. We're going to transmit to the appropriate receiving facility. You may have remembered me talking about this particular thing if you've watched it under our medications and pharmacology presentation, where we talked about a little bit of the protocol. You remember, if you're suspecting somebody acute coronary syndrome, aspirin. They're getting aspirin. You're going to assist them with their nitroglycerin. Also, remember the protocols that go with that and the limitations, sensitivity to aspirin and allergic to aspirin, nitroglycerin, vital signs, systolic above 120, and they can take them. Okay, so keep that in mind. Remember, Dad's only a phone call away. Dad, aka the doctor on the end of the resource hospital radio or phone call. So I digress. So when we do a 12 lead, it's great. Unfortunately, we don't have a bare skin chest to use all the time. So sometimes, let me rephrase that. A lot of times This may be what you're getting. You're going to have one step away from Chewbacca. He may even growl at you like Chewbacca when you pull a razor out and says, "Sir, I have to shave your chest." But I've been working at this look for years. It's okay, sir. We're shaving your chest. Because if you don't have a good connection, you're not going to get a good diagnostic EKG. Disclaimer again, this is not to specifically show you how to do an EKG with a LifePak 15 or with a Zoll monitor or with any other commercial monitor that's out there. This is to talk about placement, transmission, and the whys we need to do this. Okay, so preparing the skin, shave the skin. If they're diaphoretic and wet, dry the skin. All right. So why is it so important to get good lead placement? We have to get accurate lead placement for EKG interpretation. So this is critical. This is critical. And I'll explain a little why as we move forward. So 12 lead placement, let's talk about it. So when we place the limb leads, we're going to place those on the insides, maybe the wrists and on the ankles. What you're looking for limb lead placement is muscular areas of the body. If we put it over bone or we put it over a lot of fatty tissue, you're not going to get good readings because the muscles in the body are they conduct electricity very well. And that is where you're going to do it. So maybe on the ankles or maybe on the calf where it's muscular, maybe on the forearms or maybe on the deltoid where it's muscular. That's okay. You'll also find people that will place the limb leads on the lower abdomen right above the hip. I'm not a huge fan of that because it kind of there's potential for a skewed representation of an EKG if you do that. Is it wrong? Not for me to say. That's for the cardiologists that argues over millimeters on an EKG. So how do I do it? I do it this way, how they're talking about it. Lower limb leads, there we go, the limb leads. According to the American Heart Association, electrodes may be placed on any part of the arms or the legs. So on the arms, they need to be below the shoulders. On the arms, they could be below the shoulders. That includes the deltoid, forearms, bicep, as long as you have a good conductible area. On the legs, they need to be below the inguinal fold anterior to the gluteal fold posteriorly, excuse me. So remember, you're gonna go down south on the leg. So inguinal fold, you're gonna get down onto the hamstrings or on the quadriceps, big muscles, right? Go down low onto the calves. Why do we tend to go to the calves and the ankles? Because it's easier access. We do live in central New York, people, and you may live in Georgia. It gets cold in the wintertime. It doesn't matter where you are. People are going to wear long pants. People are going to wear long shirts. This is what they do. One of the things we're limited to, we should try to expose skin, but we don't want to potentially do that and make the patients uncomfortable and cold, or cold. We don't want them to lose body heat also when they're doing that. So keep that in mind while we're doing this. So any other placement, this is per American Heart, is necessary by deformed or missing extremities, must be noted in the record, because you may get the shape of the tracings that we're getting when we do an EKG may be a little skewed because of that. All right. So we're looking at it. Here we are, a different diagraphic. You have red, yellow, black, and green. So as you see on here, you're not necessarily going to have yellow. Most of the time you're going to have white, truthfully. But the white is going to go white on the right, on the patient's right arm, and then smoke over fire, which is not showing on this diagram. So the RA is the right arm, will probably be will be white. This is totally skewed. I like this. I'm going to delete this. I'm sorry. So white, just remember, white goes on the right, then black goes on the left, red goes on the left arm, excuse me, and the red goes on the left foot or leg, and then the green goes on the right leg. Okay, white on the right, smoke over fire, and then I guess we'll just plant some grass. Wow, bad slide. Anyway, this one's right, however. Chest leads V1 through V6. As you're looking down, you're looking for the fourth intercostal space to place V1. Find the fourth on the right side, and then on V2, fourth intercostal space on the left. Then it's easier if we go down one intercostal space, mid-clavicular, you go straight down from the clavicle and place 4, V4. And right between V2 and V4 goes V3. You put it exactly right in between them. And then V5, we're going to follow a line down from his shoulder and kind of draw a straight line down to the bed that the patient's sitting on. And V6 is going to go mid-axillary, which is straight down from the armpit. All right. So locating the suprasternal notch, and then we're going to locate the angle of Louis. If you watched any videos on interosseous needle placement, and when they did a sternal one, that's the landmark they're going into, is that angle of Louis. But if you look down, angle of Louis, as you see in the diagram, that is the second rib. That's where that comes in. So you count down from there. Or you can start at the clavicle, 1, 2, 3, 4, piece of cake. All right. So we're going to find the second intercostal space on the right side of the sternum, and then it's going to be that space is directly below that second rib. So if you're going to do the angle of Louis, that second rib down, underneath that, 2, 3, 4, and there we are, V1. Right? Good. Follow the angle of the Louis to the patient's right until it articulates with the second rib. Locate the second intercostal space. From there, count down 2, 3, 4, and then V1 is going to go on 4, just like we said. Place V2 across from that on the left side of the sternum, and then V1, V2. There's the placement. And you see the amount of chest hair in there may be able to make contact with the skin, and that's good. You don't need to do any landscaping there. But if you remember, if somebody has a hairy chest and you go to take these off, it could be painful and sound like Velcro. That's bad. All right. Unless their wife's there, you let them do that. The wives will be all over doing that. So V2, you're going to find the fifth intercostal space. So one more down, right? You're going to put V4, and there you go. You're going to put 3 right between the two of them. That is the correct placement for that. And then V6, mid-axillary line, and a level with V4. All right, then 5, going to go down from the shoulder. 4, V4, V6 is all level with V4. So they're drawing a straight line down to the bed, right? See how they're leveled out? There you go. Suprasternal notch. Angle of Louis. Counted down. Fourth intercostal space. V1 and V2. V4, that's in the fifth intercostal space. And then you have mid anterior axillary line, or you could head straight down from the shoulder and then mid axillary line, which straight down from the armpit. That is your placement. Okay. All right. So now, why is it important that, where's a good, why is it important that placement is correct? When we talk about placement, think about where the heart is. The heart, let's see here. Here's a laser pointer. So the heart is here in that area. So each of these, if you were to picture these as cameras, they're taking pictures of different angles of the heart. Okay. And then this is down a little low. I do believe that is meant to be out here. And just like this one is supposed to be meant to be out on his shoulder. These are, it's either, you either have a view coming from this to these, or these to that particular lead. That's why we have the limb leads on there. So when we get done, we look at 12 different views of this. Make sense? So each of these are a little camera looking at different angles of the heart. So when we see on the monitor, when we run this, we are going to be able to visualize what is happening in that particular angle of a heart. And we could identify an active ST elevation MI by doing that. And an ST elevation is what they'll see on the EKG in a certain portion of the rhythm strip. More to follow in advanced EKG rhythm reading. I invite you to continue your education after EMT class. Excuse me. All right, we talked pretty much in depth about that. That's good stuff. All right, so positioning. We are going to have our patients sit at 45-degree angles. So remember our patients that are having respiratory distress. We want to sit them upright. But if you need to get a good diagnostic EKG, you got to recline them a little bit. So down to 45 to 30 degrees if you can. They need to have their hands down to their sides, their limbs are relaxed and supported. So rest your arms on the railings of the EKG, put them on the bed, wherever they are. Patient has to stay very still because it can throw what's called artifact into the rhythm and make it so we can't read it. And then we have to, obviously we're going to attach the lead wire to the electrode first before we put them on there, because you'll be pushing into the patient. The electrodes, the sticky portion, attach the lead wires, set it up. And while this is running, no physical contact with the patient during signal acquisition. The patient's quietly sitting there, nothing's moving. And then after the 12 lead has acquired, patient can move around, they can talk, they can do whatever. So this is something you have to be sitting still for, not driving down the road. You have to get a good initial baseline EKG before we do almost any other treatments or any treatments at all. We should be getting this EKG. So we're treating for nausea, we should do an EKG. You're treating for chest pain, and you're gonna give nitroglycerin or assist with nitroglycerin. We should get an EKG first. We should get a set of vital signs. All of that type of stuff comes together. This is so. Don't think of an EKG as a treatment. Think of it as an assessment. So, and again, this is going to be specific for the agency you're working with. If you are, this is to give you a broad general overview of what the EKGs are about. So, all right, then we're going to quiet. They're going to be quiet. We're going to hit the 12 lead button on any monitor you're going to do. There is a procedure on each monitor to do that. On each of those monitors, it's also going to ask you for the age and the gender, because with the age and the gender, it's going to actually give a electronic diagnosis of that. So it's going to obtain the EKG. It's going to look at that, and just how when it receives that data, it can accumulate that data, and it can look at the age, it can look at the gender, and look what qualifies for STEMI or ectopy or whatever we're looking at on an EKG. It's going to use that information for the computer will use it to diagnose the EKG. When it diagnoses it, spits it out, has what we call up on the top of any of them, will give you the diagnosis. Suspect ST elevation MI means you need to do something about it and go from there. So if the monitor detects noise, the 12 lead will be terminated. So you can't do that. So that goes back to please be still and movement. So sometimes it will do this when you've done everything you should have done correctly. Remember, if you have patients sitting up too high, it's too straight, lay them back a little bit. Might clean it up a little bit. You may need to move limb leads so it cleans it up a little bit. The goal here is to get a good, clean reading and tracing, as they call it, an EKG land, so it can do a diagnostic EKG. Diagnostic, you know it's diagnostic if it spits it out with a reliable diagnosis on there, but when you move on to rhythm interpretation and reading, that's not the end all. We need to be able to identify that ourselves. So if the monitor is identifying something and we look at it like as a paramedic, and we look at it and we're like, that's not what that is. That's where we come in, part of the training. But for you guys, definitely, if somebody's having anything that falls underneath anything cardiac suspected, and you've done a 12 lead, ship it off to dad. You're going to transmit that. So women, goes back to why we got to put this information in. Remember, women, we're going to need to be worrying about modesty. So make sure we're in private, right? So it's okay to not totally expose a woman to the world. You have blankets, towels, you can cover exposed skin if you need to. If obviously we have to move anatomy to do that. If you're moving a woman's breast, make just the back of the hand to move it out of the way. So we remain professional and clinical while we're doing this. So if possible, have a female crew member do this. Use the back of the hand, or you can have the patient lift the breast themselves. You'll find a lot of patients they will not worry about modesty at all. That's great, but still do everything in your power to preserve their modesty. Keep a bra in place if you can. I don't necessarily totally agree with that because it might interfere with placement. However, if you can leave it in place, that's good too. It just eases down the line there. So, and then here we go with what are we looking at for an EKG? This is actually produced by a LifePak 15, a physio control device. So when we do that, we'll print it out. It may come out that it's identified this as ST elevation MI, because it sees where is it happening. For us, we see, okay, I see it has depressions here and elevations over here and over here and up in here and maybe up here. So we're like, okay, yeah, that's a STEMI. When we get this printed out, we're like, great. The next step is we need to transmit this to the hospital, so the hospital knows what's come. So note for transmission: HIP is a huge thing. However, when we're transmitting EKGs, we're doing it for a reason. You need, whatever monitor you're doing, you have the ability to enter patient information in there. So put a name under an ID, put their birthday. So when the hospital gets this, they're able to take this information up here with the name, and they're able to go pull an old chart and pull an old EKG, and also pull the history and meds and everything else that goes with this chart to be able to assist them in treating this patient and getting them the treatments they need in a timely manner. So if this came in and you've done everything right, the cardiologist will be notified. You'll walk in with this patient. They'll say, hi, how you doing? Slap you high five, check the patient in, and have you all go to the cath lab. If you go to the cath lab, you get to watch the whole thing. It's pretty cool. However, it's even better when you activated the whole process to start this down the line. It started with your phone call and your transmission of this EKG. Good job. Excellent work. There are so many other medical devices besides the EKG that you're going to be utilizing. When you get to your agencies, most of the agencies out there are showing you how to do 12 leads and operate their equipment. We call it ALS Assist where we're at. Other agencies call it other things, but that's what it is. Because when you work on an ambulance and you're working with a paramedic or a level 3, you're a team, or another basic for that matter. You're a team. Everybody has their jobs to do. Paramedics going to be doing treatments and that kind of stuff. They may rely on you to do this EKG. So awesome work when it comes to working as a team. All right. All right. There's another. I hope that was enjoyable, and we will see you on the next one.